For more than 30 years, millions of women have turned to Healthy Women for answers to their most personal healthcare questions. Maternal health is of huge importance to our audience, and we deliver expert content and resources to support her throughout her pregnancy and beyond. And at Healthy Women, we make it our mission to promote access to care for all women. That's why I am thrilled we are having today's conversation. We want women to know that there are treatment options for pregnant women and moms with opioid use disorder. And we want healthcare providers to recognize that there are significant barriers to accessing treatment. We want to help reduce stigma around the issue and break down the barriers of women living in secrecy and anxiety. And we hope through this conversation, we begin to do so. Now, I would like to introduce today's moderator, Greg McNeil.
Thank you, Beth. I'd like to kind of set the stage, if you will, by just talking a little bit about opioid use disorder and maybe the difference between opioid misuse and addiction. Dr. Terplin, beginning with you.
Well, thank you. And thank you for inviting me and for being here. And I'm really looking forward to this conversation on a topic that's, I think, particularly near and dear to all of us, which is really the intersection of substance use, misuse, and addiction, and reproductive health and gender. So I use those words, like substance use, misuse, and addiction. And use is sort of self-explanatory, using a substance. Misuse means, using it in a way that confers harm or in a way that's not as prescribed. Can be endorsing that you like the effect of a substance. It can be crushing and snorting something instead of, swallowing it, and etc. And use disorder or addiction, which are almost, I'm going to say we'll treat them as synonymous, is a disease state, a condition, an illness, defined as use disorder by the Diagnostic Statistical Manual. But addiction we think of as a brain-centered condition, but it affects, the entire body. But the primary symptoms of addiction are really behaviors. Compulsive use, craving, and really the salient feature is continuing to do something is harming yourself and others and being unable to stop doing it.
So let's discuss words and the power that words have, both from a positive perspective and a negative perspective, to impact the patient. Beth, let me call on you to address stigma and the language we use.
Stigma, it's a pretty scary word, right? And I think what I'm seeing and as a practicing nurse is that so many people, as soon as they hear or see on a chart that the mom tested positive for an opioid, there's an automatic reaction. There's a reaction and a judgment that's placed on that mom, and it doesn't go away through her treatment, through her entire stay at the hospital. And there's also a stigma placed on that baby, not a harsh one, but just one of worry, concern, and why. That whole question, why is this little life subjected to this? And it's very sorrowful. So I would say there's a huge need to destigmatize how we're managing these patients and these people.
So, and there's other hurdles that they have to overcome here. So when a pregnant mom is experiencing and going through substance use disorder, particularly opioid use disorder, she's incented to keep this a secret and to keep it from people. So that intensifies the struggle and puts up yet another hurdle, doesn't it? Shruti, can you speak to that?
Sure. Women usually face many unique barriers when they're trying to access treatment. For example, there's still many states with punitive laws in place for pregnant and parenting women. 23 states and DC deem substance use during pregnancy to be child abuse. Over half the states and DC require a healthcare provider to report suspected prenatal drug use. In Tennessee, when this law was in place, 100 women were charged with fetal assault between 2014 and 2016 under such law. Another example is Alabama, where 479 women were prosecuted between 2006 and 2015 under the chemical endangerment law, and most of these women couldn't afford an attorney. Women also face significant, consistent discrimination. As Beth said, stigma, but we also like to use the word discrimination because this is discrimination against people with substance use disorder. And only 10 states prohibit publicly funded drug treatment programs from discriminating against pregnant women. And as a result, women are much more hesitant to seek treatment for fear of losing custody of their children, for having to give up their children as a condition of treatment. And studies have consistently found that these punitive laws do not work. They don't reduce neonatal abstinence syndrome, and they don't prevent women from using substances. But here's what they do. They put up, because of these punitive laws, women not only don't receive treatment for their opioid use disorder, but they also don't receive essential prenatal care, thereby potentially causing harm, not just to the fetus, but also to the mother.
Nancy, how have you seen this play out on the populations that you serve?
Well, I can agree more with all of the ideas that people have presented about the barriers that women are facing and the shame and the stigma. I think this really can be traced back to the hysteria that we saw in the 1980s with the crack epidemic, where we were focused on the effects of the maternal substance use on the children to the detriment of the moms. We didn't really concern ourselves with the pregnant addict or the moms that were facing addiction. And so, moms have actually internalized that. And we see that women are actually really stigmatizing themselves at this point. So when they are looking for treatment or thinking about the need for treatment, the automatic, idea that they're going to have their children taken away from them, they could be facing some imprisonment if they are identified as substance users, that they have to actually maybe ask for permission from a partner, in order to seek treatment, that they are going to lose a partner. So these are some of the things that the women that we see on a daily basis are facing. And that's just the tip of the iceberg.
So on top of all of these hurdles, you also have some that are gender-based. Can you speak to some of the differences that gender makes with substance use disorder, Dr. Turplin?
Yeah, so just clarified a bit of terminology. So we could talk about sex-based differences, which are, based presence or absence of reproductive organs and some assorted, like hormones, although that less so, and gender-based, by which we mean gender roles. Gender is a social construct, and there are both sex and gender-based difference in terms of vulnerabilities to development of addiction, to overdose, and et cetera. For one common sort of denominator across is the real epidemic of gender-based violence in the United States, in particular, childhood sexual and physical and emotional abuse. And these are, under the larger umbrella of what we call ACEs, adverse childhood experiences. First published, the data first published around the turn of this century, and really changed how I think a lot of people thought about adult illnesses and development. And there is really almost a dose-dependent correlation between number of adverse childhood experiences and lifetime substance use, injecting a substance, and development of addiction. And since gender-based violence, since children, like girls, are more likely to experience sexual abuse than men are, we see a differential burden of behavioral health by gender in the United States. women bear a larger behavioral health burden. Women are more medicated than men are for mental health conditions in the United States. We also see when women present, we talk about sort of what's called telescoping. That means the time from first use to development of a use disorder is shortened in women compared to men. These data are most developed for alcohol, but we see it also with other substance use disorders. And not only is the time shortened, but when people present for treatment, women tend to present with more severe use disorder than men do. That being said, outcomes, even in, like programs that are not sort of gender aware or gender specific or anything, outcomes tend to be quite gender equal. But women tend to, start using substances later, have a greater burden of trauma and PTSD, and present for treatment with, generally speaking, more severe disease.
So now let's pivot over to access to care and treatment. And doctor, I want to stay with you. Tell us a little bit about when pregnant women get screened and how that all works for opioid use disorder.
Yeah, let me do, maybe this is the last language piece. And this is, and so I mark a difference when I talk about this between screening and testing. And Beth mentioned testing, at the time of labor and delivery. And testing means it's an evaluation of a biological sample, usually urine, for the presence or absence of particular drug metabolites. There's, nothing in a drug test. It's, I said addiction is a behavioral condition. There's nothing in a drug test results that tells you anything about a person's behavior. In other words, it's not a test of addiction. And it's certainly not a parenting test, which is how it's utilized in the real world. It's a moral test. It's a parenting test. It's a test that labels people as deserving or undeserving of motherhood. Testing is actually there. It's slightly different conversation, has a role in addiction treatment, but really we have to really think critically about what role it has, if at all, really in labor and delivery. What is recommended is screening. And screening really means talking to a person about substance, about drugs, smoking, drinking, and other substances. There are validated instruments that can be utilized, can be integrated into an electronic health record that can aid in that process. But those, somebody completing a survey is really meaningless if the provider doesn't engage in a real, like, person-centered, non-judgmental conversation with the individual around substance use. So screening is recommended by all, professional societies and, public health agencies to be integrated, as part of actually primary care in general, including, prenatal care. Now, whether it happens and what people do with the results is a different question.
So someone comes up positive. At that point, are they referred? What happens?
So I would say, when we think about integrating, which is really what we're talking about, integrating the domain of substance use, misuse, and addiction into prenatal care, it's going to depend a little bit on context and capacity of that clinic. So a screening test, is not a diagnosis. Being positive, so to speak, on a screening instrument for substance, use does not confer a diagnosis of a use disorder. But I would say any physician or any provider actually can walk through the DSM and could establish a diagnosis. It's quite simple. It's really 11 questions. And then you count up the numbers that are positive. So it depends what happens. But ideally, like, the screening instrument the result needs to be incorporated into, a conversation with a patient, and in collaboration with that person, establishing a diagnosis, getting a sense of what their goals and plans are, navigating them to appropriate level of care, providing that care yourself. If they're not ready for treatment, seeing them until they are. We know from literature going back to the 1970s that even if we provide prenatal care to people who continue to use drugs, they have birth outcomes that are much more similar to a general population than to people who don't engage in care. So even engagement in care, even just continuing to come to prenatal care, actually, greatly reduces preterm birth, low birth weight, and et cetera.
So there's a lot of incentives for them to kind of avoid detection. So when you sense that that's happening, how do you deal with that, Beth?
How do you deal with, say the
Keeping
question.
opioid use disorder a secret, a pregnant mom.
They
How do you
don't go
help
to,
them?
they don't go to prenatal visits. That's, you know, the one patients that we see that are trying to keep it a secret are not going for prenatal visits. So they're just getting pregnant and then coming to deliver the baby.
So
Okay.
I want to push back though a little bit, Greg, on this
Okay.
idea that the people are somehow incentivized to non-disclose. And I will say that people can have very legitimate reasons for not sharing personal and potentially family destructive information with a provider, and that the burden is on us, you know, to one, create a welcoming environment, and two, you know, work to undo harmful policies. But I have yet to meet the person who's pregnant, who uses drugs, who doesn't care about her health or the health of her baby to be, and isn't actually seeking information, you know, about how to, you know, be more healthy in her pregnancy, and doesn't express concern for what her behaviors may or may not be doing. Usually she overstates what she thinks the risks are because that's the media perspective, you know, and does not have concern for it. And if we provide, you know, like a welcoming space that's not, you know, non-judgmental, and work, you know, to protect information and to really support people in recovery, I have not seen that sort of incentive for non-disclosure.
Yeah, I agree.
Mhm.
I would agree with that 100%.
Yes.
I'm saying what I'm seeing
Likewise.
right now today is unfortunately the opposite, right? You're seeing because there hasn't been that space provided for the mom to get the information and to take care. We're seeing many more moms coming in that are not having the prenatal care and delivering, unfortunately. And that's why this conversation is so important, so we can start bringing awareness and providing some examples of what is working so we can continue to change that.
So what are some of the risks that moms need to know about for their baby, both to them as well as their baby, for opioid use?
Well, I mean, for the moms, I mean, it all depends, right? So we have the moms that come in that end up testing positive. We have to immediately call social services, and the baby is put on what is called a hold into the nursery, and the Division of Family Youth Services, or DYFS, is called. And that's when the conversation begins with mom. And until they come to an agreement, the baby is kept in a nursery, and there's one-on-one care with a nurse that has to score the baby, because chances are the baby's going to go through withdrawal. And so that's where the problem is. And I think, Nancy, you probably can speak to this too, because you're taking care of a lot of those moms that are released right after
Sure.
maybe a DYFS hold has been put on the baby and the mom, right? And if the
Well,
mom.
So we're in a different scenario because we have taken moms into treatment who are basically being managed and have prenatal care, and a lot of times are now on medication assisted treatment, usually methadone, but sometimes Suboxone, which, you know, recently was approved for, you know, use during pregnancy. So we work with a local hospital where we have a collaborative arrangement. They're very accustomed to working with our clients. We also have a very healthy and collaborative working relationship with our local county children and youth department. So if there are protective orders or you know, arrangements being made about the aftercare with them, you know, we're working closely with them. Most of the women also have intermediate care workers that are assigned to them, so they're navigating with them through the system. So, you know, lots of things have changed, even, you know, very rapidly over the past just 5 years, even with a, you know, massive influx of money from the federal government. toward this problem. And I think we're using it wisely. But again, the other barriers, of course, for the women themselves to be, self-disclosing, identifying, and proactive is, part of the systemic problems that they're facing. And of course, COVID isn't helping that any. So anyway, we have women that are delivering babies here, that are having managed care. And what we do then is work with them after the babies have been delivered. They have gone through withdrawal that's been medically managed in the hospital. And then they come back and they usually have a very extended stay here at Liberté, somewhere up to 4 to 6 months postpartum, where treatment is provided and a lot of supports. So that, we have a very successful outcome in, mostly every case.
So postpartum depression has to be a big part of what you see, and it has to be exacerbated, I would imagine. Can you speak to that, Nancy?
Well, that is an excellent point. So I'm sure that the doctor can, definitely speak to it probably a lot better than I can. But what we see is, of course, a very high incidence of co-occurring mental health disorders. And we also see a lot of emotional dysregulation because, of course, pregnant women are typically taken off of psychiatric medications, which is what is necessary during a pregnancy.
Not.
I think, from what I've heard, I'm not a medical person, but I've been in this field for decades and decades. So managing the emotional dysregulation is extremely important because for women, emotional dysregulation is the #1 cause of a relapse, as opposed to men. Men typically relapse around a celebration. So a good event in a man's life will typically trigger a relapse, where a woman having an upset, a depression, and anxiety, something that's, triggering a PTSD experience. So for us, we have a lot of environmental cues and a lot of things around our setting that help to manage things about our community setting in terms of the supports that we give so that we're able to help women cope. The coping skills are really the most important thing that we're able to help, to provide the women. And then, of course, all of the parenting skills in the world that we can, help to bring to the moms that are here.
I want to pivot back to Dr. Turplin on the medication, and you've got a different view of pregnant moms needing to go.
No. What I was responding to, so I think this is a more general statement, and that providers are somewhat afraid of the pregnant person, and they're they're very concerned primarily, and I think Nancy laid out the history in the crack baby, hysteria well. They're primarily concerned, sort of for fetal well-being and not for maternal well-being. So what can happen is somebody who's not used to taking care of people who are pregnant can be like, oh, you're pregnant, you better stop all your medicine and go see your obstetrician. And for some medicines, for many medicines that can, there are very few medicines that are contraindicated in pregnancy. There's a lot of medicines that we don't have, pregnant people are not until the COVID, to a large extent, are not included in drug trials. And so the absence of data doesn't mean that there's a presence of harm. And the big picture is that untreated depression, is actually worse for the fetus than treated depression, even with, medications that we know, are associated with developmental risks, such as lithium or something. So that's sort of like it's not uncommon for people to be, I think wrongly, taken off of their medication. And to me, this sort of reflects how we think of pregnant people as this quote unquote special population. And although I do think they have different, sets of vulnerabilities that we create as a society, but are not inherent to pregnancy biologically, so to speak. And so, yeah, so we should, one thing providers should not do is cease all medications, as soon as somebody becomes pregnant.
And just to add to that, Craig,
Go ahead.
we've also seen that because of this, treatment is so much more difficult for pregnant women to obtain. So just a recent study that was published in JAMA, I think it was just earlier this year, used trained actors to found that pregnant women were 20% less likely to be accepted for treatment. And this was mostly with outpatient buprenorphine providers. And yet both methadone and buprenorphine are the gold standard of care for pregnant and parenting women. And this is consistent across the board. We've seen these in other studies too, that providers just don't want to treat pregnant women with opioid use disorder. And then sometimes it's also a question of whether they have the expertise. So currently only about 19 states have programs that are specifically designed for pregnant and parenting women.
Sure.
The rest of the states, there just isn't a program for these women. So it's great that Nancy's clinic has the capacity to do this.
Yeah, we're one of only 18 programs in the state of Pennsylvania. So it's a very large state. And we're in the metropolitan Philadelphia area.
Yeah, it's amazing. I just wanted to jump in because I think that's a piece that I think is so important, Trudy, because what we're seeing is women that come in, Nancy, on methadone, right? Many of the OBGYNs that are seeing them do not know how to manage those patients, right? So once they deliver, the methadone needs to be titrated down. And
Not
many of those
necessarily.
or not necessarily.
Are you talking about for the baby or for the mom? Because it is not indicated for the mom.
So for the mom, most of our OBs don't even realize like what needs to happen once the mom comes in. So they're not used to managing a mom on methadone. And so that is a huge hurdle. And there's needs to be education on how to manage these patients.
So I would say that it would not be up to the OB to manage the mom's methadone maintenance. That isn't the role of the OB. And in fact, it is usually not indicated for a mom to titrate down, in my experience anyway. Of course, the baby's withdrawal is what needs to be managed by the care in the hospital. A lot of babies, which may be surprising, do not even experience withdrawal symptoms. Moms are typically encouraged to nurse their babies, which helps quite a bit with withdrawal for a lot of reasons. It's the soothing part, in addition to them getting a calibrated, dose of methadone. There's a lot of, environmental ways to manage the withdrawal for the babies. And there is some post-acute withdrawal syndrome that the babies can experience, but it's not as frequent and severe as you might expect. So,
but I think that's where there's a huge disconnect. I think there's a need to do a lot more education for those moms when they come in to deliver, not only for the doctors, but for the nurses that are caring for them, and the NICU and the nurses in the nursery too, because we're seeing, and it's not, and here's the other thing too, when we're talking about stigma, it's like never judge a book by its cover. And I was taught that at a very young age. And, where I work, I'm working in a very affluent area in New Jersey. And I work as a per diem nurse, meaning that I do 2 shifts a month. And every time that I'm working, even last Friday when I worked, I am taking care of a patient that is addicted to opioids. And it's not the person that you may think in the back of your mind, but it's the soccer mom that was prescribed an opioid for injury she may have received and never went off of it. Right. And her is like, my doctor prescribed this and I've been on it for X amount of years. So
Well,
I'm just saying, this conversation is so needed, but I just want to reinforce the need to educate, not only, yes, consumers, but also there is such a need to educate the healthcare profession on how to manage these patients successfully.
And also to add to that, it's not just important to educate healthcare professionals on how to manage this, but also understand the law in your state.
Right.
So for example, there are many states where just because you've suspected use in a mom, that you don't need to report at that time. The only time you need to report is once the baby is born and the baby exhibits neonatal abstinence syndrome. So just understanding the nuances in your state and knowing when to report, when you don't need to report. And a lot of times when you have to wait to report, but if it is the baby that experiences NOWS or NAS, you have the time then to get the person into treatment, get them on a medication. And once they're on a medication, then that is no longer reportable. So again, understanding those nuances, it's really important for not just physicians, but the nurses that take care of these patients to understand the laws in their state.
Couldn't agree more, Shruti. Not agree more.
And
Are there resources, Shruti, that-
complicated. I had a patient in New Jersey who was on Suboxone and then became pregnant.
Mm-hmm.
And, and a professional woman, as you were indicating, and it was, fraught with concern because she was worried about getting obstetric care just because of that. And there she was managing her addiction legitimately. She was getting treatment for her opioid use disorder.
And in many states sometimes there are two separate forms. So you might need to report that as someone who is in treatment and continuing treatment through the pregnancy, but not necessarily reported to child abuse. Again,
Correct.
You would just have to contact your attorney and talk to someone who can really dig into that law and tell you what is reportable, what is not, if there are different forms to report this, so that Child Protective Services are not called when they don't need to be, and that proper care is given to both the mother and the child.
I mean, to me, this really illustrates how, on the one hand, we say addiction's a disease, it's, belongs in the public health sphere and, not in the criminal justice space, yet, the proximity of, policing to clinical care is nowhere closer than it is really in the birthing hospitalization. And we don't actually treat, addiction as a disease, as witnessed by precisely, like this conversation. And I think until we until we sort of uncouple what families and communities need from U.S. drug policy, we'll be stuck in this, sort of cognitive dissonance. Lots of people need help. Families need resources following delivery. People who use drugs also need resources, following delivery, but it's not that the Venn diagram does not completely overlap. And I think it's, in many ways, like we're clogging up the child welfare system with, with reports and notifications that are just noise and distracting from, from the rare, like serious, like neglect and harm that can happen. And we're tearing apart families which is of consequence, across those kids and the mother's lifespans. So until we sort of take this out of this criminalized space and expand the lens and really not think about like child abuse, but think about child poverty and address that. I think it's an example of how we're stuck in a particular mindset.
Over the last year, we had additional challenges with COVID-19. So how has that changed the way that you've approached treatment? And what are some of the positives that have come away that you'd like to see go forward? I'll open that up to whomever wants to respond.
Well, I'd like to respond to that. The first thing that was of great concern is that as a congregate care facility, the demand for treatment plummeted. people were just so concerned about living in this type of a setting. The second thing that happened, though, is that because we treat the indigent, we found that we absolutely had to keep our doors open despite every challenge imaginable. Even at the fear of our own, lives, we had to keep the doors open because we were taking moms with children that were literally either here or on the streets, and pregnant moms too, pregnant women too. So COVID was just, a challenge that we never thought we'd ever have to face on top of an opioid epidemic. We thought that that was beyond all proportions, and then this. The other thing that happened is that the demand for treatment was really kind of wonky because people have access to a lot of pandemic assistance, and that's driving up a lot of drug use and a lot of overdoses. And that's extremely frightening for the treatment field.
So just to add to what Nancy said, pandemic definitely led to a significant spike in opioid and other drug-related overdoses, and many factors contributed to this, including isolation, increase in mental health disorders, financial strain, burnout, and all of this disproportionately affect women. So a record number of women left the workforce or downsized their careers during the pandemic. And at the same time, those same women have reported burnout and difficulty balancing both work and their personal responsibilities. There's also been a 25 to 300% increase in reported cases of domestic violence against women. Mental health disorders such as depression and anxiety have skyrocketed, and those disproportionately affect women. And then, as Dr. Turplin said, women, or I think Nancy might have said this, women end up developing, or it ends up exacerbating their substance use disorder when these things all coincide. So when there's a spike in mental health disorders, when there's divorce, when there's burnout. And during this time, the access to treatment became even more crucial. So the one encouraging thing we did see was that the federal government and states did relax some regulations as it became, necessary to increase access to treatment. So for example, states had declared a state of emergency can request a waiver for opioid treatment programs to dispense up to 28 days of methadone for stable patients and 14 days for less stable patients. The Drug Enforcement Administration also issued new guidelines about prescribing controlled substances during the pandemic. So for example, data-waived physicians, those that can prescribe buprenorphine, can now initiate treatment with buprenorphine via audio only and don't need to do that in-person visit. So this has all been great, but again, these are only temporary solutions that need to be then made permanent as the COVID pandemic ends up decreasing.
Yeah, as you just illustrated really nicely, Shruti, like how COVID exacerbated like inequities like that are part of our society, racial, gender, income, and etc. And I would agree that one of the silver linings was really around remote services, and not just the prescribing. And yes, it's under a temporary, sort of regulations, but like telehealth is not going to be put all the way back into the box. Exactly what it looks like post-pandemic, we don't know. And it's not just for the prescribing, it's also for other types of care. We found with one clinic, the clinic I used to run in Baltimore, Maryland, when they opened up remote teleservices in the postpartum period, about 20% of people used to come to their scheduled postpartum visit when it was in person before the pandemic. Some people had a scheduled in-person one during the pandemic. It was still 20%, adherence. But the remote visits, it was almost 90% of people connected with a provider. So having the ability, and then really having the ability to get reimbursed for that care, which is a different kind of question, but having the ability to connect with people in little bits of time, more frequently at their own, in their own, space, wherever that is, it speaks to the principles of what we call sort of harm reduction, meeting people where they're at and helping to get them to get to where they want to be. And especially for like people with children, where you go, you have to take however many buses to get to the clinic. You sit in the waiting room, with your kids for like a 3-minute visit. I'm not surprised people don't come to that appointment. Like we have not done our jobs as providers to make that easy, welcoming, person-centered, accessible, but the remote technologies do. So I'm hopeful. I don't know exactly what it will look like, but having more tools almost always is more better. And having the ability to engage people remotely as well.
And as you mentioned, those are two great points, which is the increase in telehealth and remote services and meeting them where they are. And studies have documented over and over again that women who are allowed to stay with their children during treatment are more likely to start treatment, maintain treatment, and retain treatment. So one of the things I did want to highlight was a recent study that has been started by Yale University. About 12 clinics in Connecticut and Massachusetts are training with Yale to offer OBGYN care and treatment for substance use disorder under one roof to pregnant women. And they're doing it as sort of two ways. One is through a collaborative care model, which includes medication plus a recovery coach that becomes a one-on-one source for support throughout the pregnancy and then 3 months postpartum. And then the second way is through their extension of community healthcare outcomes, where they use video training and mentoring to help clinicians at these other locations treat pregnant women with opioid use disorder with medication. And they're hoping to enroll about 480 women. And currently, as of 2 weeks ago, they had only enrolled about 30. So hopefully this gets the word out and more women can enroll in studies like this, where they feel safe, where they can keep their children there, where they really can get treatment, not just throughout their pregnancy, but also postpartum.
Yeah, and you're highlighting, I think, like something that hasn't come up yet, which is sort of the roles of peers, people with lived experience, recovery coaches, lots of different names and differences in work, but under that sort of big general umbrella. And when we think about what the healthcare system looks like, it's really, it's built for the convenience of the providers, not the person. It's organized historically and to some extent by body parts, and rarely does an individual experience a condition that just fits into the boxes that we have built. And then there's like, different types of care, right? Inpatient, outpatient, residential, et cetera. And we can provide great care within that box, but people don't live within the box, and where it's the spaces between what we've built where there's attrition, where there's loss to follow-up, and where we need programming and the way to do that, to create the glue, for a true system of care is really, through people power and leveraging, people with lived experience, recovery coaches, peers, and et cetera. So yeah, thank you for mentioning that.
Trudy, is there any other states, or Dr. Turpin, you may know too, or Nancy, anyone, who's doing it right? So it sounds like Yale's on the right path, right? With launching this whole new kind of progressive way of managing mom and baby. Is there any other states that are doing it? And Philadelphia or Pennsylvania, Nancy, with your amazing.
Sure. Yeah, so we have, we just finished a pilot project with the Health Federation of Philadelphia, and we had collaborated with them through Bucks County, putting together some funding to support this project, where they embedded a therapist at Liberté, and the therapist provided maternal child psychotherapy. And this was based on a 2-gen model of treatment, which shows that if the maternal child attachment is strengthened, then the substance use disorder treatment is also strengthened for the mom. And there's lots of evidence for that. So the pilot was very successful, and the program was given 5 more years of federal funding, and we're launching the next round. We're really excited about it because there's now a second part to it, which is called MIO. It's Mothering from the Inside Out, which I guess everybody knows since you're nodding. It's about, reflecting the emotional state of the child. So again, this is all going back to trauma-informed care. And as the doctor mentioned, adverse childhood experiences of the mom, and reflecting on those experiences and relating those to what the child may be experiencing. We're looking at applying this to moms who, we don't just take pregnant moms into treatment, we also take women who bring their children with them to treatment, up to 3 or 4 children at a time, up to the ages of 12. We have a mom who's coming into treatment with 4 kids soon. We have a licensed daycare center here. So we're really excited about those types of projects that we're doing. Another thing we're doing is participating with Access Matters. They're an organization that received some funding around opioid use disorder too, and they're looking at providing reproductive health and contraceptive access to women who have opioid use disorders, and they're providing those services right here at Liberté. So I think those types of collaborations that are cutting across all of the issues, the things that you've mentioned about, kind of one-stop shopping or all services being under one roof. We do have an outpatient program here, and I think it's just, wonderful to hear about the success of telehealth, and I hope it persists, because our psychiatrist has had 100% compliance with our appointments for our outpatient clients. When does that ever happen? Because again, even if we were to go pick up our women, bring them here, provide daycare, provide meals, we still don't get 100% compliance. So I think telehealth is another, wonderful thing that's come about that we hope, we're going to continue to capitalize upon. So we have a long way to go. And again, we just are faced with decades and decades of failed social policies. We can't possibly turn it all around, in instant. We see a lot of women that are in the criminal justice system. Probably 75% of the women who come here are coming here on drug court or probation or parole. So we have criminalized this disease, and it's too late for a lot of those people. They have already been ground down and caught up in this system, and the effects of that on their lives are going to be long lasting.
What policy changes should be made to state and federal, at the state and federal level, to really make a big difference in this and help us move forward and get away from this punitive policing policy that we have, and help us to address substance use disorder for what it is, a chronic brain disease? Shruti?
I think just that, which is treated like a disease. In terms of criminal justice, Nancy made a couple good points, but let's talk about some of the good things that they're doing. So Rhode Island, for example, Rhode Island jails help anyone with a substance use disorder receive treatment, including with medication, as soon as they come into their correctional system, and that includes pregnant women. So this is wonderful, so that pregnant women are then teamed up with healthcare systems and are receiving the care that they need. But even before this, they get into the criminal justice system, there's a lot of wonderful pre-diversion programs. In Florida, for example, we know of a few counties that have hired through their police department, through their sheriff's department, actually counselors. So they have hired civilian police who go out there and try and treat this as a disease. And before they even get into the system, try and team up these individuals with treatment programs instead of getting them even into the criminal justice system. So that's one thing, is really focus on pre-diversion programs that help these individuals with this disease get treatment as opposed to get into the system. If they're into the system, then help them again receive treatment as opposed to just having them go through withdrawal and relapse and take other, self measures to try and treat their symptoms. And then the third thing is that we still have so many barriers for access to treatment. So for example, you can prescribe methadone for pain without having any barriers, but to be able to access methadone for opioid use disorder, you have to go to a federally registered opioid treatment program. Same thing with buprenorphine. They have to get a Data 2000 waiver, and even that, there's restrictions on how many people they can treat, which again needs to be removed or at least loosened so that more people who need treatment can have access to treatment. The statistic hasn't changed for years. Only about 20% of people who need treatment have access to treatment. More than half the counties in the United States don't have a data waived physician. So we need to make sure that access to treatment is increased and these restrictions on treatment are removed.
A little earlier, Nancy mentioned some very innovative and new programs that her company has instituted. So have you seen innovations that have happened over the course of the last couple of years that you'd like to share with our audience?
Not to split a hair, and definitely not to minimize, Nancy, your program, which is fantastic, and also not to minimize like what the new, the program that's being rolled out at Yale. But I would say that the principles behind this are actually not new. And have, and were really first, described by Loretta Finnegan at the Mater Clinic in the 1970s.
Yes.
Integrated co-located service delivery has been considered the standard of care based upon the research from that period of time. And when I said earlier that people who engaged in any care at all had, improved birth outcomes, dates and has been reaffirmed, every decade since. But it's almost as if people kind of, every turn of the wheel rediscover this idea of integrated comprehensive co-located services and brand it as something new. It's definitely, unfortunately, remains new because it hasn't clicked. And why hasn't it clicked? Some of it has to do with the feast famine, federal response to drug crises. I opened up an outpatient drug treatment facility in Richmond, Virginia, about 5 years ago. And at the time, the institution was like, "It's so great that this is our first outpatient drug treatment clinic." And I was like, "No, it's not." Virginia Commonwealth University was one of the second wave of NIDA, like perinatal funding, and had a clinic in the 1990s that provided comprehensive care, for people who were pregnant and used drugs. After the federal money sort of dried up, following the loss of attention to cocaine specifically, and maternal health and substance use as well, the clinic, the university didn't provide continuing funding for it. This was something in the rearview mirror. Not only was the clinic closed, but its memory was in many ways completely erased. And now we're in this period of upswing, which is great in terms of funding, and when it's allocated correctly, which Pennsylvania is doing to a large extent. Not everybody is doing it perhaps quite as well. But I think we have to ensure, that we are able to, provide continuing care when the attention shifts away from this crisis, as it always does, as it always will. The type of drug kind of goes up and down across, time in the United States, but the overall presence or population health burden of substance use and use disorder remains relatively the same. Um, and uh, and so I think, it's not just thinking about the individual with a use disorder and having more of a chronic disease management for it, but thinking about public health from that chronic disease, sort of from that life course or societal life course perspective, how to, create programming that is truly sustainable. And not, and not solely, on the, sort of really sometimes the whims of federal and state grant monies.
So what can we do as policymakers, healthcare providers, et cetera, to make opioid use disorder more of a priority in our systems? Beth?
I think, just listening to this conversation, I think there needs to be like a public service announcement, like a huge educational campaign on this disease and really look at it as a disease. So I think if we can start doing that, and then again, I feel like I've been saying this, but more education to both provider and consumer on the condition. But I think we need to normalize this and do a big education program. And I think bringing in some of these real women, examples of people that have successfully managed this disease is so important too, right? Because once you see and hear people that have gone through this, it helps destigmatize, right? And this is what the education program is it helps destigmatize and makes it more real for everyone else. And so that would be my wish.
Repeal the punitive laws against women with opioid use disorder and parenting women with opioid use disorder. They don't work. We've seen that consistently. And again, it's a huge barrier for access to treatment for both opioid use disorder and prenatal care. These laws need to be repealed.
And I would just rephrase that as like to decriminalize healthcare spaces. That we are not, the ethical and humanistic and really what motivates us as people who work in this space is not like what sometimes like people feel that they are mandated to do. That's an inherent conflict. I think we need to like really kind of like decriminalize like healthcare. And think about how to change drug policy to make it more reflective of true population, quote unquote harms. We have this dichotomy, well, there's three things. There's like a prescribed substance, there's a legal substance that's not prescribed, i.e. tobacco or alcohol, and there's illegal substances. And of course, cannabis is sort of mixed across all three of those now. But but we assume that means something biologically or public health wise. That prescribed things are safer than legal things and illegal things are the most harmful. And for the context of, a pregnancy, that's actually not true. There's prescribed medications that cause birth defects. There's the two legal medications. Certainly alcohol is, the leading cause of preventable, intellectual disability in the United States. Yet these punitive policies are not reflective of population health harms. They're reflective of this, social legal, distinction that is grounded in, drug policy and society, not in, biology and public health. So I think uncoupling that would be huge. The second thing, though, I think is not just, we talk about health insurance as sort of a proxy for health care, and it's not, but it's a okay place to start, but really thinking about like, so if so we'd say all the time, addiction is a chronic remitting condition, right? But we only really have ever provided episodic care. So if we give people treatment, stop treatment, give people treatment, stop treatment, give people treatment, stop treatment, the disease might stabilize, recur, stabilize, recur, stabilize, recur. So is that what we think of as the natural history of addiction really the natural history of addiction, or is it also in part an artifact of how we have, treated it, which is episodically? So I think providing people with access to care, which really means providing, people with health insurance, having, that is continuous, and is essential.
Mhm.
Beth, what would you like our viewers to take away from this session today?
That opioid use disorder is a disease, and that there are some hospitals, that there are some states that are doing it right, and that we can learn from people that have a blueprint. We don't have to start from ground zero, and that this has been going on for a long time. This is not something new. And so if we all work together to raise awareness, to educate, and to work on policy as a team, as partners, I think we can make a big change in 2021. We need to. I know I don't want to be here in 10 years talking about the same issues.
Nancy, same question.
Sure. So women with opioid use disorders are not just addicts, they're also moms in a lot of cases, and that can be extremely motivating and positive, and can help moms want to get into treatment, and can be very encouraging to them and produce really wonderful outcomes for them, not just for them, but for their children and all of their family.
Trudy?
That opioid use disorder, as Beth said, is a disease. It should be treated like it. So remove all of these punitive barriers, improve access to treatment so that someone can be on a medication for the rest of their lives and not be considered, quote unquote, an addict. That means that they are in treatment and that they're leading a successful life. Continue looking at treatment options, continue giving access to innovative long-term care, and removing the punitive barriers.
Dr. Turplin, we'll give you the last word.
And we touched on the postpartum period, but perhaps insufficiently, because there have been so many other wonderful things to talk about. So, when people are pregnant, doors open. Individual motivation increases, societal concern, although there can be judgment and prejudice and discrimination, certainly they're there. There's something there that we can provide people. Because of how we fund healthcare, because of how we built the system of care, people there's very little touching of the healthcare system that happens by people with use disorder in the postpartum period. This is a time of increased vulnerability. This is where people return to drug use, where OUD recurs. In many states that have looked at this, overdose or drug deaths in general are the leading cause of maternal deaths. Something we expect to see only, tragically increase during the COVID. So I think, thinking about how to continue care, in the postpartum period, using, the silver lining of the COVID, to meet people where they're at, using remote technologies, to utilize, peers and sort of innovative, even sometimes informal networks, to help, support people and to flip the script. I mean, I definitely completely agree with placing this within a disease kind of framework, but to flip that script somewhere to be recovery focused, that it's not just that treatment is available, but that recovery is possible. And there are many, many people, in recovery.
Well, I want to thank you all, our esteemed panel of guests here, for participating in today's program, and Healthy Women for organizing this important webinar on a topic that, just gets so little discussion and needs so much more attention. Healthy Women also like to extend a special thanks to Brayburn for their assistance with the formation of this webinar topic. And for more information on this topic, please visit healthywomen.org, where you'll find information on opioid use disorder, as well as links to important resources that we discussed today. So thank you for joining us, and have a great day.